Okay, well, listen, thank you very much for the invitation. And as Piangela mentioned, I'm a professor in electronics engineering in DCU. I was away for a few years on a leave of absence, and I set up this company, NuWaveSensor technology. And so my talk today is going to be a bit of a mishmash of contributions from that company, DCU, and so other collaborators, including Chagas and the RCSI. And it's an example of so digital innovation to improve air hygiene and air safety, and my focus is on in clinical applications. So I'm just trying to move my slide here. So the context is that the transmission and proliferation of contaminants, pathogens, and other things in the air is poorly understood and poorly managed. Usually, airborne contamination, things like the virus and so on, are invisible to the naked eye. They're very difficult to detect. And in a clinical setting, can be a significant vector of transmission of healthcare associated infections, and things like resulting things like Legionnaire's disease, aspergillosis, infection from MRSA, and so on. But also non-biological contaminants such as allergens and dust particles and so on can also lead to respiratory illnesses such as asthma, allergies, and others. So we have an invisible contamination source. And on the right-hand slide, what I'm trying to show is that there's sort of three ways we deal with it. So first of all, it's containment. The second thing is monitoring, and the third thing is observation. And what I mean by this is it's an invisible thing. It travels through the air. We all know the difficulty with the virus, so this is very topical. Is it airborne? Is it not airborne? Is it in droplet format? Is it viable or not viable? So we contain it to things like cleaning, filtering, laminar flow of or air management, isolation, and whatnot. And in an attempt to keep the virus or other contaminants at bay, and particularly in the clinical environment, and particularly in certain wards, such as leukemia wards, cystic fibrosis wards, and so on. So the first line of defense, I suppose, is containment. And the second thing is periodic manual monitoring. And so I'll give an example of how that proceeds in the next slide or two. But it's a discrete process. But usually, and unfortunately, the evidence of an infection source in a clinical environment is often firstly observed in the patient by clinical observation. So people tend to get sick before there's an awareness of the presence of a particular pathogen, which is obviously far from ideal. The metric around air quality is used more and more, particularly over the last several months. And I've broken air quality into two distinct things: air hygiene and air safety. So air hygiene is things such as just, everything to the comfort of your rooms, your indoor air temperature and humidity, things that affect your overall wellness, such as odors, particulate matter, ventilation levels, which can be measured from carbon dioxide and other gases that might be present otherwise indoors. That transitions then into air safety. So things in the air, such as pathogens that can harm you, or in this case, because it's more of a clinical discussion, immunocompromised patients, for example. So it's important when you're worried about air safety to get a detailed picture of things that can contribute to it. So things like particulates and so on, while they can be harmful in their own right, they can also be a source of which some of these pathogens can travel from A to B. You will generally have some sort of a flora in the air, so you'll have a broadband airborne pathogenic load, but then you have specific pathogens that you may be concerned about dependent on the area that you're trying to protect. So it could be bacteria, it could be mold, it could be virus and whatnot. So there's several requirements. And I suppose what I'm trying to say here is that one tool doesn't do all the jobs. So you sort of need to know your context and what you're trying to protect. And over the last several months, because of this coronavirus, there's been a shift in focus from wellness. So you may have heard of standards around buildings, around well buildings and so on. That's fine, but I think we've seen a shift now from that to safe, assured and reassured, and it's been dramatic over the last several months. Briefly, I'm talking about clinical environment today, but it applies at home as well. We spend about 90% of our time indoors. Indoor air can be up to 5 times more polluted than outdoor air. The trend towards energy efficient buildings and so on, while understandable from a sustainability perspective, it can lead to the buildup of contaminants indoors. And common home items such as dust, pet dander, mold, smells from cooking, aerosols, and so on, all these things can trigger asthma attacks and other allergies. And most of the time, we're not aware of what's in the environment. We've no way of measuring it in any proper, tangible way. Just getting back to the clinic. So I mentioned that measurement is important and it's a manual process. So the current approach, by and large, of sampling for a pathogen in a clinical environment is detailed on the slide there. So you start off with some sort of an agar plate, so it's like a dish, an 8 centimeter dish in which you have a jelly-like material on it. You walk along, you bring a little machine with you, you take a sample, let's say a cubic meter of air, it takes about 20 minutes. Then you take that sample, you package up, you send it to a lab, either an internal lab or an external lab. Oftentimes it's external because it's quite specialized. Someone has to sit down with a microscope, look at it, incubate it first, then look at it, make an assessment, then write a report and send the report back. And that can take up to 2 weeks, not unusual. So it's a very manual process and obviously not fit for purpose, and certainly not fit for purpose in the new world we're living in. So this manual process with multiple steps is ready, if you like, for digital transformation. So what we've been working on is taking that manual process and automating it. And by that I mean we take the sampling piece, we send it back to the lab piece, we take the incubation piece, and we take the analysis piece, and we wrap that all in what we call a cyber physical system. So essentially a machine, it sits on the wall, it samples the air continuously, interacts with the cloud, makes an assessment based on what it measures, and produces a report. So all that process that takes 2 weeks, you can do in several hours using a digital process. Now, I would say it's not, we're replacing a microbiology lab. It's like we have, rather than replacing the kitchen, we're replacing, let's say, we're creating a bread machine for the kitchen. So it's a very, very focused activity looking for specific pathogens that are airborne. So essentially you have as an IoT system, all these sensors need to be connected. You need to measure a range of different parameters. It's useful to have on my bottom left-hand side there, I'm just trying to illustrate, in a mesh, because when you're dealing with, for example, hospital, you have multiple wards, so you need these things potentially to interact. The fact that you can interact with the cloud means you can do analytics, you can do visualization, you can have apps, you can have automate systems, all sorts of things that you can do that will be difficult to do with a manual system. Also, if you think about it, so let's say we had measurements in a ward that was able to give us some idea of the risk of airborne transmission of a disease. So my little triangle, my little rectangle here is pretend hospital, and I have 8 wards. So I could, if I based on the measurements in those wards and other contextual information, I could actually produce a number that would be, let's say, the risk of transmission based on humidity, based on particulate levels, based on the microbial load and whatever, okay? And that's fine, okay, individually. But in truth, the risk profile is also substantially impacted by its proximity to another source of contamination. So if I have St. Mary's ward and I have St. Joseph ward and I have an outbreak of something in St. Mary's ward, then obviously the risk profile for St. Joseph ward is is increased. And the Internet of Things, the fact that you've got sensors, the fact that you have a cloud, means that we can get an awful lot more sophistication, if you like, into our assessment of the risk of contamination in a certain ward. And once you know that the risk is elevated, then you can take some corrective action in terms of additional cleaning or moving patients or staff or whatever. So for example, here's an example from something we worked on in a nursing home. So you have all these different rooms in the nursing home, and in each case you can assign some sort of a number or a heat map around the chances of a transmission occurring. Now, obviously, this is only a risk. So, but if you see the conditions are elevated, then you will be advised to take corrective action. And of course, contextual, as an external contextual information, is also important. So, what I'm saying here is you can take environmental measurements that are intelligent. They can be real time. They need to be continuous. They measure the critical things that are important, depending on the things you're trying to protect against. You may acquire additional pertinent contextual environmental data, such as the time of year, the weather, has it been pollen, daytime or nighttime, has it been raining or not. Then interaction from users. So you can also get users to, how they're feeling. Is there a progression of coughing? Maybe log those events. All those things can feed into your risk model. So your risk model, combined with other external environmental inputs, combined in a sort of a cloud-based system, will allow you to make more precise and more useful, I suppose, provide more information for protecting an environment from airborne contamination. It's an IoT system, so it's easy to apply things like machine learning and pattern recognition and all that, but obviously privacy and security is paramount. And in the design of any of these systems, and that has to be at the forefront of your mind. So this awareness of air hygiene and air health is more prevalent than it has ever been. I just picked this from a newspaper article in the last couple of weeks from a Professor Orla Hegarty in UCD, where, she's highlighting the fact that, the design and the ventilation and, how you manage the internal environment is hugely important in managing, in this case, is COVID-19 or SARS-CoV-2, how you manage that or how you prevent as much as you can. Not a digital thing, obviously, but you prevent as much as you can the conditions from happening that would encourage the proliferation through the air of this virus. Similarly, from the Financial Times for the week before last, I think it was, again, in fact, this week, it was also an article around this air pollution, air contamination. In fact, last week's Financial Times had an article on COVID transmission in the air and so on. So it's becoming very topical and much more awareness of the need for change for better systems. So if I was to say the old world versus what I call the new waves world, but it's really the digitally transformed new world, okay? And just in the context of airborne contaminants and dealing with it. So sample taking, frequency set at weekly, monthly, yearly, or not at all in most cases. And it's manual, one point in time sampling. You walk along with your agar dish and you get a result. You compare that to something that's always on, it's proactive, it's automated, and it provides cloud-based analysis so you can get the right information in the right place. The monitoring uses a very complex laboratory which can do millions of other things, as opposed to some sort of a very focused analysis just for the airborne contaminants. You report in days and weeks, as opposed to minutes and hours, because of course it's local and it's immediate. It's disjointed. Lots of things can go wrong in any process that has many as people and labs and trucks and posts and people looking at things, where you replace that with a machine that's contextually aware, it's got historical information, and it's got all the relevant reference material to hand. And then you have disjointed systems with no linkage between the testing results and the response systems, or you can have a digital system which can be integrated fully into your process flow, into your clinical systems, into air conditioning systems and other machines for managing the environment. So essentially, we're replacing an analog type world with a digital world for this problem set, which, as I said at the start, is becoming more and more relevant. Well, I apologize, it's always been very relevant. I think our awareness of it has become more and more pronounced. For example, we just have a project funded from Science Foundation Ireland with partners in Teagasc, the RCSI, NuWave and DCU, looking at detecting the presence of the virus in the air in areas such as hospital wards, reception areas of hospitals, that type of thing. And we will have, we've deployed systems all over the world for bacteria, but for the virus, we're hoping to have a system in place in Beaumont Hospital at least before Christmas this year. There are many challenges. I'm presenting a 15-20 minute overview of a huge amount of work. There's a lot of challenges in terms of regulatory. In fact, there is very little structure to the regulatory landscape in this regard across the world. Different jurisdictions have different requirements, and in fact, a lot of the time, it's more recommendations rather than law. What we're trying to deal with here is multifaceted. It's complex technology, it's microbiology, it's molecular microbiology, it's electronics, it's RF systems, it's data science, veracity, and the system technology has been able to interact with people who may not be particularly technically savvy. Legitimization, as in testing, proof of performance. You're dealing with very dangerous bugs. You're dealing with very dangerous bugs in different scenarios. And then integration into clinical systems. So what happens if you have a detection? Detection might be false. You don't want people running out of the hospital unnecessarily. So you need to understand how the information is used, how it's presented, the veracity of the information, and all that complexity. So we actually have managed, in NuWave at least, we've shipped many hundreds of units across the globe so far. When we've also shipped units into clinical systems, but we're still at an early stage, I would say, because that whole piece of managing the information, and it's complex information, and it can be information that the hospital doesn't necessarily want publicized. How do you deal with all that? And that's the end of my talk, 20 minutes exactly. Thank you very much.
Thank you very much, Stephen. While we wait to see if any question comes up on the Q&A, I have a question of my own. I don't know if is NuWave a spin out of DCU, or is there be any link between the research ongoing in DCU and the actual product?
Yeah, it's based in DCU Alpha. So it's got offices and labs elsewhere as well, but it's primarily based in DCU. And yeah, it has collaborative projects with DCU on various topics.
Okay. And also, I'd be curious to see what's your view, or if you've done any study in terms of try to estimate the return on investment on this kind of solutions, this kind of, say, architecture really for detecting air quality and air hygiene. I mean, I bet it must be skyrocketing these days with COVID, but generally speaking, have you done any kind of research or estimate in this space?
Well, in a way, it's easier in other sectors such as food processing and manufacturing, where you know your typical yield, you know what you spend on monitoring and so on. In the clinical setting, it very much depends on the jurisdiction. So, like as I said at the start, sometimes these things aren't measured, so there's no current overhead. But of course, there's a cost in dealing with problems. So, like the numbers are ridiculous if you think about if you prevent healthcare associated infections associated with MRSA in a hospital, particularly in the US, for example. So from an ROI perspective, the numbers are silly. It's enormous. But not fully proven out in the clinical environment because it's difficult to put a number on what's currently spent. It could be nothing, but that's not fair either, right? I mean, because you got people tied up in microbiology labs and sending stuff out and so on. So, but it's a substantial return on investment, yeah. And right. In fact, our motivation isn't, well, it's obviously just return on investment financially, but obviously the impact is far beyond that in terms of mortality rates and human suffering.
Yeah, absolutely. And there is then linked to my next question, there is also a question coming through the Q&A there, which is essentially you mentioned hospitals, you mentioned nursing homes, but then what other applications, what kind of other verticals or sectors are you actually targeting with these kind of solutions, or are more interested in this kind of solutions?
No, we've got we would have deployments in IVF clinics, for example. We're working, now we haven't got deployments yet in medicinal cannabis facilities where mold is an issue. We're working with a couple of food-based multinationals in the US looking for Listeria and E. coli. So we'd have a wide variety of deployments. IVF clinics is important for us actually because there's one or two molds that are very important that you prevent in that environment. So it's broadly deployable. For today's talk, I just focused on clinical, but
yeah,
bugs are different and the integration is different. So in different environments.
So one of the questions here is, are you doing air quality project in the agri sector? Is there mostly related to food processing or more general?
We are. We in Ireland we work with Teagasc, and we're working with Teagasc on bugs related to meat processing and aspergillus, which is a type of mold. In the US, as I mentioned, we've got a few projects in, I said, medicinal cannabis being one, and then a very, very large company that make beef burgers and sort of meat processing. So,
okay. And another question here from Chris: is the product used domestically as well as hospitals? If not, should it be?
So we have a product called Care. I had one slide, which we sell via with Bosch and Siemens and Neff. So they market for us that in the US and in Europe. And that's a residential air quality product. It measures a number of different parameters, but it doesn't as yet measure pathogens. That's a lot more complex, obviously. So, but that's something that we will be doing, but not on the short term and not on our own.
Okay.
So,
and then I also have one more kind of technical question here. It's more a curiosity more than anything else. But so when I was looking at your presentation there, seems to be lots of parameters being considered, and then as you mentioned, it's a mix of data science, microbiology, and all different disciplines all happen, say, all brought together into one solution. So I guess it's, as you said, it's a complex problem. And then my question is, I see that you're using cloud and cloud computing infrastructure behind it. But then are you actually using a mix of cloud and edge computing and anything in between, or everything happens in the cloud and then the results get sent back to the actual device?
No, it's a mixture of both. So for example, we would do some image processing on the edge and just send back pertinent information to the cloud. So the cloud, with cloud, we do lots of things in the cloud, but the primary thing we do in the cloud is you would aggregate the data from the individual sensors to produce an overall risk model for a building, for example, or a city or whatever. So, to answer your question, there's a mixture of both. We try not to spend too much information over the RF system. So you do whatever pre-processing you can locally, and then you send the pertinent information back to the cloud.
All right, that was great, Stephen. Thanks a lot. Thanks again for your time and for joining us today. It was very, very interesting.